Thank you so much, Char. It's great to be here with you all. I am joining you from Brisbane, where it is 8 o'clock at night. So please, I do apologise if I'm not as sparky as if it was 8 a.m., but it is lovely to be here with you. Okay, so look, this talk has come around through a very nice message from Alvin over the internet, asking me to speak a little bit about our checklist for electronic medical record implementation. So what I thought I would do is explain a little bit about digital health in Australia and particularly in Queensland. We probably have the largest investment in Australia in Queensland, so I'll talk a little bit about that. I'll talk a little bit about some of the research that's happening, and then I will actually talk through our implementation checklist for electronic medical record rollout, but also digital transformation. So those two things are slightly separate, and we'll pick those apart in the talk. Please feel free to put questions in the chat. I will leave plenty of time for questions. So looking forward to the discussion at the end. Before I do start this talk, I would just like to acknowledge the traditional owners of the land I'm speaking from today, which is the Turrbal people. I pay my respects to their ancestors and their descendants who continue cultural and spiritual connections to country, and I recognise their valuable contributions to Australian and global society. Okay, so I'm not sure how familiar everybody is with the geography of Queensland. I must admit that I lived for some time in Makati in Manila when my dad was visiting professor in Manila. So I have been to the Philippines. I do not speak much Tagalog, so I won't even try. But I did think it was important to talk a little bit about geography. Many of you will understand the challenges of distributed geography and distributed population. So Queensland is increasingly becoming a very regionalised state. We have large populations distributed across the eastern seaboard. The green circles represent centres that have an instance of our electronic medical record. And I'll talk a little bit around this, but I guess just to show you the scale of the electronic medical record here in Queensland. All the way from Cairns up in the north down to the Gold Coast. This is actually a single instance, which is kind of interesting because it is a single instance across this huge geographic area. And the distance that our single EMR spans is 1,700 kilometres. So that is a huge distance. And for my European colleagues, I always put that into perspective by saying it's the same distance from Paris to Warsaw. And I'm sure that there's actually an equivalent in Asia, but certainly it is a very, very long way. And all of those people are on a single instance of an electronic medical record. So you can imagine the challenges around culture, around workflow that we've had to overcome to get such a large group of people on a single instance. I thought I'd just show a little video to give you a little bit of an overview as to the size and scale of the EMR that we have implemented here in Queensland. So I'll just play this video, which we have put together from the University of Queensland. And importantly, we are not just thinking of the electronic medical record as electronic paper. So when we really, I guess, started out on this journey, it was really around swapping out paper for an electronic medical record and just recording that information digitally. What we've realised is that actually is a bit of a waste of time. And actually what we're after is not implementation of an EMR, but digital transformation. And digital transformation means not just putting in an electronic medical record, but harnessing the compute power of the information that you're entering. So I'll play the video. I won't play the whole thing. And then we'll get back to talking through about what some of this means.
The following presentation is intended to help researchers gain an understanding of some of the common data elements captured within the Queensland Health's integrated electronic medical record for use in potential future research projects. The integrated electronic medical record, or the IEMR, is now used in Queensland Health's digital hospital sites in lieu of the traditional paper-based documentation systems. This complex adaptive system integrates with multiple health systems, feeding information directly into the patient's electronic medical record. Such a digitally enabled system has the benefit of being completely auditable and provides a rich reservoir of data captured with the ability to extract for research purposes. The IMR consists of a large arrangement of applications which provide clinicians and support staff with a platform to provide and document patient care. PowerChart is the heart of the product and replaces the paper-based chart. The breadth and depth of the functionality available within PowerChart will be explored further on the slides to come. Additional ancillary applications also exist which are used extensively and include, but are not limited to, the SA anesthesia module, which is real-time pain management, allowing anaesthetists to view patient parameters and previous medications administered to formulate effective pain protocols, whilst nursing continues at the bedside. Medication administered in the intraoperative setting is recorded and matched against future orders to reduce potential errors. It also enables better patient preparedness, pre-workup and post-surgical care. PharmNet is the pharmacy module enabling review and verification of medication orders placed in the system requiring potential supply. SurgiNet is the surgical information management system, which contains theatre and equipment scheduling, case tracking, perioperative nursing care documentation, and electronic preference cards. It offers continuous documentation from pre-admission through to the post-operative care. There are currently 16 Queensland Health sites live with the IEMR, 14 with the full stack, which is the advanced IEMR rollout, including electronic medications management, anaesthesia, and power trials applications. So what are the benefits of using an IEMR? Digital transformation enables the use of routinely collected data to continuously monitor and improve healthcare outcomes, facilitating what is known as a learning healthcare system. In turn, a learning healthcare system can better equip organisations to achieve the quadruple aim of healthcare. To give an idea of the current usage and volume of transactions undertaken within the Queensland Health IEMR, noting that the first hospital to go live with the full suite of IEMR applications was the Princess Alexandra Hospital in 2017, and the volume has been steadily increasing to these volumes at current day. There are approximately 27,000 users logged into the system on any given business day. There's 1.6 million electronic orders placed per month and over 130,000 clinical notes signed per month. There's a huge storage capacity for the data being generated, with the database size currently sitting at 37 terabytes plus 80 terabytes for scanned documentation. There are approximately 8,500 back-end data tables where the information is stored. To give you an example, the clinical event table currently contains over 4,000 million rows. There are two different formats for data stored.
Okay, I'll stop there, but I guess that gives you a sense of the size and scale of the electronic medical record in Queensland. And we are certainly up to, I think, around 40,000 users a day in a single instance. So I'm happy to talk about the challenges that scale does present us with, but it is now the largest electronic medical record in the Southern Hemisphere. So when I was speaking to Alvin online, I guess his question really was, how did you generate evidence to proceed with your implementation? And I think the answer to that is we didn't do a very good job at the start. So we were learning. But what we have done is realize that we need to set up some academic rigor around what we're doing. And so the Queensland Digital Health Centre at the University of Queensland has been established just recently with the aim of undertaking research to help us understand electronic medical records and how to use the data that we're generating safely and ethically to improve healthcare. And really what we're trying to do is, I think, create a learning healthcare system. And that is where the information which is gathered during routine healthcare is analysed and the findings are used to provide better care for the next patient. And that continuous learning is such an important benefit of electronic medical records. And I'm sure many of you know that when you are implementing complex technology such as an electronic medical record, there's a lot of pressure on you to deliver the project on time and on budget. And no denying that's important, but actually we've tried to elevate our aims away from project aims to healthcare outcomes aims. And so we're really saying that we need to deliver not just a project or an implementation, but we need to deliver the quadruple aim of healthcare. And I'm sure many of you know that is a better quality of care, better efficiency of care, better clinician experience, and better provider experience. And balancing those four things forces you to stop just focusing on delivering a project, but actually asks you to take on the ultimate aims of healthcare. And that's really important when you get stuck into complex project work. This learning healthcare system is really evolving quite quickly in Queensland. We are using data from electronic medical records, wearables, and we are starting to use that data to learn, to deliver better healthcare the next time we see a patient like the one we've just recorded information for. And we are really careful to think about, what does good look like? So does good look like just putting in an EMR? Probably not. But good for us looks like delivering on the quadruple aim, and putting in an EMR or any other form of technology is just a tool along the way and not an end in itself. So we've really had to evolve our thinking away from just a successful implementation to delivering on the quadruple aim of healthcare. And that's an important evolution that we've had to make in Queensland, because nobody's going to fund or invest in a successfully delivered project once it's done. People will fund and think about investing in ongoing efforts to achieve the quadruple aim of healthcare. So how do you attack such a complicated and lofty idea in a measured and sensible way? And many of you will be, I guess, in some ways overwhelmed by all the buzzwords out there at the moment, you know, artificial intelligence, precision medicine, and we absolutely subscribe to all of those terms, but we've had to be very strategic about how we get there. So we have wildly enthusiastic clinicians who want to do precision medicine tomorrow. And so we've had to educate ourselves that this is an incremental approach, that we have to do it in a staged manner and work our way through those different horizons, as we call them, in a way that is sustainable and fundable. And so we've really created this 3 horizons approach, our digital transformation strategy, where Horizon 1 is really actually about just digitizing healthcare. So that is just putting in electronic medical records. You cannot progress across digital transformation unless you've done that. So that is Horizon 1. How do you put in an electronic medical record and digitize your workflows? Horizon 2 is then about taking out that data and computing it. And I can't emphasize again how important that is in terms of delivering value on an EMR. And we put a lot of resources into understanding how to extract that data, how to analyze it, privacy and ethical issues, to create those analytics products that allow us to understand how we're performing as a healthcare system and how do we work smarter. Horizon 3 is really about taking those digital workflows and those data and analytics and developing new models of care. And this is where you really start to deliver on the quadruple aim of healthcare. Just putting in an EMR is not going to deliver on the quadruple aim of healthcare. You need to actually create new models that actually deliver on that aim. So an example of that might be, we put in an electronic medical record to record all of the blood sugars digitally in Horizon 1. In Horizon 2, we create a dashboard that allows us in real time to see which patients are having high blood glucose levels and which patients are having dangerously low blood glucose levels. So that's the Horizon 2 component. And then Horizon 3 is we actually create a role for a new digital diabetes nurse practitioner. And every morning, this nurse practitioner comes in, looks at the dashboard, can see who's had a high sugar, who's had a low sugar, and goes and sees them first. And that's very different to the traditional model where our nurse practitioners used to start at the top of the hospital and walk down, seeing patients one by one to understand who'd had troubles overnight. So that is really reimagining healthcare and using digital workflows and data and analytics to create new, more efficient, better models of care to deliver on the quadruple aim. So that's how we're approaching it. very strategic, very layered, and we are working on all three horizons at once. But this conceptual model allows the clinicians to understand that we have to go through this if we want to get up to precision medicine and AI and machine learning, right? We have to go through the pain of Horizon 1 and Horizon 2, and importantly, the investment required for Horizon 1 and Horizon 2. Okay, so Horizon 1 is digitising healthcare. What are we doing there? So this is a paper where we actually tried to understand our digital health maturity. And this is important because it's very hard to understand what you need to do next from a technology perspective unless you don't understand your digital maturity. So this was a collaboration that we undertook with HIMSS. Many of you will know HIMSS, where we actually assessed, and I can't believe I did this now in retrospect, we assessed the digital health maturity of every public hospital in Queensland. And that was a big deal, you know, over 100 hospitals. But it did allow us to really understand how we're going as a jurisdiction, how mature we are, and what we need to do to improve our maturity. So Horizon 2 is data and analytics. So using some of that data that we've collected in our electronic medical records and our digital workflows to create some analytics products. And here's some examples. So we know that extracting data from electronic medical records is really tough. It's hard. So we published this paper in ACI last year, where we actually looked at the literature to try to understand the best way to do this. Because, you know, in Queensland, we've got this big electronic medical record and we just didn't quite know what to do. So obviously we went away and had a look at the literature. And we found that there are technical issues, clinician issues, and patient issues that are all involved in moving from Horizon 1 to Horizon 2. I won't go through these in the interest of time. I'm happy to discuss it, but this has really informed the way that we start to produce our analytics. And we're very lucky now that we actually are able to produce extracts from our electronic medical record as frequently as every 15 minutes across that huge database. So this has been enormously helpful. And then we've started to apply that in terms of really setting up our infrastructure for a learning healthcare system. So really an electronic medical record is just the foundational work. It really doesn't satisfy that quadruple aim of healthcare. It simply sets you up from a foundational perspective to then move into your data engineering and your care model engineering. And sorry, I do sound a bit like an engineer here, but unless you've got your electronic workflows in, you can't engineer the data, and so you can't engineer the care. And so this paper was very important for us in understanding that. So some examples of Horizon 3 new models of care. This paper, I think, does help a little bit in terms of understanding how wearables, so again, new model of care, can actually create new ways to look after people. And again, in the interest of time, I won't go through this, but we examined a huge number of papers looking at how we can think about using data from devices that people wear to re-engineer their care models. Lots of information that we found and that we're actually doing. And again, in the interest of time, I won't talk it through, but this is really important to think differently about how healthcare is delivered now that you're digital, rather than simply making the same process that you've always done electronic. Okay. I'm going to move on to the checklist, which is really why Alvin asked me to come and speak this evening. And this was really, I guess, a reaction to the very first implementation of the electronic medical record here in Queensland, in Brisbane, where we really weren't sure, actually, what we needed to do to prepare. So we had a vendor who, of course, had lots of ideas, but we were really unsure of what best practice was. So this was the very first big, large university hospital to adopt an electronic medical record in the country. And so we really were, I think, not quite sure on how to approach it. And this checklist, I hope, is helpful. And what we've realized through this process is actually there's two things that we needed to consider. One was putting the electronic medical record. And that's important. And that is a huge foundational piece that you need. And I think what we possibly didn't do well enough at the start was understand that that's just the beginning. And so putting in the electronic medical record is important. It's disruptive. It's horribly expensive, but actually it's just the start. And so we actually evolved this paper a little bit to include a checklist, not just for putting in your electronic medical record, but a checklist for digital transformation. Now, remember, your electronic medical record is just Horizon 1. Digital transformation is Horizon 1, putting it in, but also Horizon 2, which is your data and analytics, and your Horizon 3, your care model engineering. So if you just focus on putting in an electronic medical record, that's all you'll ever have. So what I think that we should be doing is placing an electronic medical record in the context of digital transformation and being very clear with our funders at the start of this journey that the electronic medical record is not the end and it's not digital transformation. It's simply putting an electronic medical record in. And so you need to be thinking not just about putting the EMR in, and that's a massive job, having done it several times, but you also need to be thinking about Horizon 2. How are you going to harness the compute power in that EMR? And how are you going to use your EMR and your data to engineer care models? Because that is true digital transformation. Okay, so our objective was to understand both of those things, both electronic medical record and digital transformation. And this paper aims to define the steps that best prepare hospitals for both EMR implementation and also for digital transformation. We used a formal methodological framework here with literature reviews, interactive workshops, draft documents, workshop proceedings, and ongoing iterative feedback from senior clinicians. In the end, and I'm sure we'll circulate this paper afterwards, the checklist comprised 19 questions. So 13 related to simply how should you put in an EMR? And don't underestimate that. I don't want to belittle or make that task seem insignificant, because it's not. It's one of the largest disruptions that your health service will ever undertake, but also forcing you to think beyond that, to acknowledge that an EMR implementation is not digital transformation, and to force you to think beyond implementation into data and analytics and into care model engineering. So when you're thinking about EMR implementation, you've got to think about your organization, your technical considerations, your training, and those are the main categories. Your digital transformation is much more strategic, and you have to think about strategy, digital disruption syndromes, and I'm happy to talk about those, and then your ongoing data and analytics and care model engineering. And those kind of seem overwhelming when you focus on simply putting in an EMR, but they're really important. Here is the checklist. So here's the EMR questions. And you'd like to answer yes to every single one of these questions, but I don't know a single person, and I talk about this quite a lot, who can confidently say, yes, we've got all of these covered. So please don't think that you have to have every single one of these perfectly aligned in order to implement an EMR. But this aim is to give you, I guess, some idea of best practice and things that you need to consider. Not everyone's going to have highly capable and responsive IT and project management teams. Plenty of us have done this, with best efforts. It's not that the hardware is always aligned with clinician needs and workflows. Sometimes the hardware comes from another country. So we had to adopt a US system, and there's obvious tension between US models of care and Australian models of care. And I'm sure many of you will experience these issues. But in an ideal world, you are able to answer confidently to these questions in the positive. And then I guess importantly in your EMR, the training and the implementation, that component there is a massive undertaking to train huge numbers of staff. So again, I'm happy to go into detail on any of these particular items if people would like. But I want to actually draw your attention to the digital transformation component of this. So if you just put in the EMR and stop there, you're never going to deliver back any significant ROI. And we know, and some of you may have seen my paper in Nature Digital Medicine where we looked at the economics of an EMR, right? And if you simply use it as electronic paper, you will never get your money back. So digital transformation is essential for delivering an ROI. And so to do things such as data and analytics and quality improvement and care model engineering, you need to have a very clear vision. You need to be able to communicate well what you're trying to do. You need to have a good culture in your organization. You need to be able to innovate. You need to have a strategy for evaluating your quality and your benefits. And you need to have the ability to engineer care models. So those are not small questions or small issues, but to really deliver on an EMR and to create enough positive sentiment to overcome the negative impacts of an EMR, this is really important. So you're not going to persuade your grumpy surgeons that they need to move over to an EMR because it's quicker or it's easier for them, because most of the time it won't be. The workflows associated with an EMR can be difficult, can include lots of clicks and be quite irritating. But if you make it clear to your grumpy surgeon that putting in an EMR is how we're going to use AI to predict people who will be have better outcomes from surgery, will deliver precision medicine to their consumers, they'll get it. And they'll put up with 18 clicks. They probably won't put up with 18 clicks just for electronic paper. So those cultural considerations around digital transformation versus just EMR implementation are really important. And I'm working with a country in Southeast Asia at the moment who is hoping to have an EMR in every hospital within the next 12 months. And we're starting to change that messaging a little bit to say that actually we're going to be delivering on the quadruple aim of healthcare within the next 12 to 24 months. The EMR is just a way to get there. So that messaging is really important. Okay, for the last little bit of the talk, and I will stop soon so we can have a discussion, is I imagine that you're all on this call because you're all leaders. So if you are part of this network, I imagine that you are highly influential in terms of technology implementation in your organization, and people probably look to you as a leader in the clinical informatics and health information space. So I thought I'd just spend a little bit of time at the end talking about change leadership. So if you are involved in leading an EMR implementation or involved in leading digital transformation, hopefully this will be helpful. And this is something that I really worked out about 10 years ago. And this is a great slide that shows you how a hospital should work on paper, right? So you've got your chief executive at the top. You've got these lovely cascades, this hierarchy of how everything's meant to happen. So presumably, if the chief executive officer says, right, we're going to put an electronic medical record in, it's just going to flow down that hierarchy and everyone's going to do that and there'll be no complaints and no problems, right? Well, I'd like to think that, but having been through several EMR implementations, actually how it works is like this, right? So actually the chief executive officer can say something, but there's a really highly influential cardiologist who actually decides what the mood of the people is going to be. And they all go and talk to her when they want to know if this electronic medical record is dangerous or not. And she might say, it's dangerous. Don't go near it. We've got to stop it. Or she might say, it's fabulous. And I'm hoping that we're going to have precision medicine in 20 years. Now, understanding that this is how healthcare works is really important. If you are leading change or you're involved in change, don't rely on this and that when the chief executive says we're going to put it in, it's going to go in seamlessly and easily. It's you have to understand that this is how it actually works. It's a complex adaptive system, and you need to understand who are those people that actually provide clinical leadership. They may not have a fancy job title, but they're highly influential, and ensuring that they are your allies and not your enemies. So transformative change is not simple and hierarchical. Transformative change, such as I'm describing, such as care model engineering, really requires you to harness a complex adaptive system and not rely on a hierarchy. Why is that? Well, because in a simple change, such as we're going to use a different sort of bandage, the chief executive can say, we're only buying these type of bandages. Now, if there's a problem with the bandage, it just goes back to the supplier and they fix it, right? The authorities just fix it. That's simple change. And that actually works quite well with a traditional hierarchy model. The problem we've got with something like an electronic medical record is it is not simple. it is wildly complex. And the problem is actually that different people are going to view the complex change in different ways. So you may have the endocrinologist saying that a particular box on in the EMR needs to be red, and the emergency physicians are saying, actually, no, it needs to be yellow. Now you can imagine the vendor trying to sort out, does the box need to be red or yellow? Very different to bandages with a problem. So both people are probably right. And the box could indeed be either red or yellow. The vendor has no clue. And so the people have to make a decision and tell the vendor what to do, because both options are correct. So this requires much more complex structures to allow for adaptive change, as opposed to hierarchical change, which is what a simple innovation is. So I guess just understanding that this is not traditional simple change, this is complex adaptive change. Thanks for the love heart there, Risha. Yeah, you're right. So if you're putting in an electronic medical record, I want you to think a little bit around your expertise in adaptive change and understanding how different it is to leading a technical change. So when we do a simple technical change, you know, we change the way that the desks are oriented or something fairly simple. It's still a desk. We're just refining it. It's not going to challenge the way the organization works. Everyone thinks desks are a good idea and we can all move the desk around. When you put in an electronic medical record, or goodness, even contemplate digital transformation using data and analytics and precision medicine, you are ending past practices. And there are people who will be heavily invested in those past practices, and you are asking staff who are likely exhausted, burnt out, overloaded to learn new ways to work. So you really need to have a compelling story around why they should stop doing what they've been doing for 20 years, put the effort in and learn a new way to work. And I would argue that simply because the boss said we need an EMR is not going to cut it. So you need to really paint a picture of those horizons of digital health, where you're trying to get to with a learning healthcare system in order for busy, stressed out, burnt people to put in discretionary effort to change. Because you're asking the organisation to work in a new way, you're challenging the value of your paper records department, aren't you? You're challenging the value of those people and assumptions around the way people work, and you're requiring new knowledge. You're going to need things such as data analysts, machine learning specialists, a whole host of new skills that may not be there in your organisation at the moment. So becoming comfortable with complex adaptive change is critical if you are to think about undertaking not only an EMR implementation, but also stretching towards digital transformation. And that means that you need a whole different sort of leadership style, right? So you still need your type A leaders, we call them. So you still need your transformation leads, your chief executives, the hierarchy, absolutely, 100%. They need to be part of a complex adaptive change. But you also need to enlist the grumpy surgeons, the powerful cardiologists, the nurse manager who everyone asks in the tea room. And those people are what I call list B, right? And they are hyper-connected people who have connections all over the place. They're trusted by everybody, and they'll question the status quo, and they will not change their behavior unless they see a really important reason that aligns with their own values. And it's list B who will stop a complex adaptive change unless they've been enlisted. So I guess just as leaders in this space, understanding who is your list A and who is your list B, and making sure that you've engaged them and that they believe in what you're doing and that your message is meaningful to them. Because you're going to see a little bit of this as you introduce the change, right? So many of you are aware of the stages of grief. And if you are a leader in this space, I have had to navigate this curve many times in my life. And an inexperienced leader will actually start to wobble when they hit the anger curve. So an inexperienced leader, when everyone's angry and saying the EMR is slowing us down, it's hopeless, we'll actually start to fall apart when they start to receive the anger. So if you are leading this change, it is entirely normal to encounter that anger as people have to change. So it doesn't mean that you stop. It means that you acknowledge that this is normal and that you work through it. There's always some bargaining as you work through this, and you do get to acceptance over time. So don't underestimate the emotional energy that you yourselves will have to put in to help people navigate this curve. It is tough. And I thought I'd finish with a little video. And this video, I think, when I was thinking about Alvin and implementing EMRs, this video kind of summarizes some of the behaviors that I've had to deal with as we implement EMRs. So I'll just play this video and see if any of these behaviors resonate with you all.
What is going on? What are you doing?
Do you understand the words that are coming out of my mouth?
Help me help you.
Don't ever do that again.
Why are you the way that you are?
I'm pretty tired. Think I'll go home now.
This is the worst.
It's not that simple.
What do you want? God damn it, what do you want?
Escalated quickly. I mean, that really got out of hand fast.
It jumped up a notch.
It did, didn't it?
All right, and I will stop there. Thank you so much for listening.
Thank you, Professor Claire. I'm surprised that you were in Manila. How long was that?
Oh, that was when I was about 13. So the 1980s, 1990s, my dad was visiting over there, visiting professor in American colonialism, and wrote several books around the American occupation of the Philippines.
Okay,
Yeah.
good.
Yeah.
And back?
I haven't been back, actually. Not since I was a kid. I will have to make the trip because I loved it. The adobo chicken, I remember that very, very fondly.
Okay, so let's plan for a return sometime soon. Thank you very much, Professor Claire, for responding to my request. Even if by email you don't know me, and well, you just heard about. I just saw your abstract. I have an alert from PubMed if there are papers that are triggered by my keywords, and your paper came out that time. I think that was 3-4 months ago. So thank you for giving us time. I know it's late over there, but we have a big group of people in the call right now. Our network is the Asia eHealth Information Network. So that's the regional side of the audience, but there are also hospital, IT executives, and IT health workers in the call, also in this webinar. So we have questions on the chat box, and I'd like to prioritize that one from my boss, Dr. Bunchay. Dr. Bunchay is the chair of the Asia eHealth Information Network. Dr. Bunchay, you'd like to open your mic and ask your question? If not, his question is, how well do clinicians embrace the EMR, and how did you incentivize the clinicians to adopt the system? Over.
That's such a good question. So there was two questions there, really. The first was, what was your reaction? And the second was, how do you incentivize it? So the reaction, I think, was mixed initially with the first hospital. So that was back in 2017. It was terrifying because there was no other tertiary digital hospitals in Australia. So I think it was mixed. I think there was skeptics, but I also think that we had enough momentum and excitement to carry it along. So you probably all know around the adoption curve where, you have 10% are the early adopters, and then you have the 20% second adopters, and then that big curve in the middle, and then the laggards. And I think what we managed to do was to actually get the early adopters and the second adopters in. So we had 30% probably from the start. And then that was enough momentum to carry the middle of that adoption curve through. We still had, I think, about 10% who were vehemently opposed to the electronic medical record. And Alvin, we actually developed a little scorecard for who that was likely to be, and we called it the Sullivan Index. And I hope no one will judge this stereotype, but it was usually adopters were the most vehement opposers, They were usually older, over 60.
Yeah.
And they were often proceduralists. So those were the 3 risk factors that we identified. And the reason for that is that those people were often highly technically skilled, were delivering absolutely beautiful world-class care, and had refined their workflows down perfectly over their career. And then at the end of their career, we're coming in with this crazy technology that disrupted all of that. And those people had what we call a sense of mastery. So it's a psychological construct where you feel as though when you go to work, you are amazing and you know exactly what you're doing, right? Because you're doing something wildly complex and hard that not many people can do. And digital transformation disrupts that, and they lose that sense of mastery. And they haven't felt like that for maybe 30, 40 years. We saw some retirements in that group who just couldn't adopt it. And there is a school of thought that says, unless you're getting a few resignations, you're not doing it right. So it's inevitable that there'll be some resistance, but you shouldn't be afraid of that. It shouldn't stop you. It is expected that you will see some resistance and some turnover in any large change. The trick is to make sure that that's minimized and managed well. How do we incentivize it? We didn't incentivize it. What we did was communicate. We said, and we were very honest, and we still are. We say that an electronic medical record isn't always quicker. It isn't always more efficient. However, unless we put it in, we will not have artificial intelligence or precision medicine in a Queensland hospital anytime soon. So we need to acknowledge that this is a hard piece of work. We have to change. It is a foundational piece. But then we're going to move to Horizon 2, and we're going to move to Horizon 3, and we will be delivering a learning healthcare system, and precision medicine come along with us. So I don't think we incentivized it, but I think what we have done in Queensland is paint a realistic picture of where we are now, and hopefully a compelling reason to continue on the journey.
Thank you. I think being able to show a clear picture is very important, because it makes it easier for the people who are not sure about what's happening to at least have a view of what we're trying to do together as a team. And I agree with you about the elderly staff who are very good at what they're doing.
Yes.
And feeling suddenly uncomfortable that they're back to being first-year residents.
Correct.
And making mistakes
yes.
side by side with the younger students and residents. And I think that's very discomforting. I imagine myself, an expert, for example, in surgery, now suddenly a novice in electronic medical record, not even knowing where to write my operative text. I think the important thing I learned is be able to communicate a clear picture and communicate the change and why we all need to make this happen. The next question of Dr. Bunchay is, who paid for all of these?
I'm sorry, not me, Alvin. I couldn't afford that. So no, it was a government initiative. So the state government. So we have universal healthcare in Queensland. It is funded by our state government, and the funding has come from the state government. I think globally we are in a little bit of a situation because the pioneers in this space were the Americans, and the Americans were given incentives to implement the EMRs, and so never really had to develop business cases, right? So there was a big incentive program in the US that Obama set up that meant that they were given very hefty incentives to roll them out. What we've had to do here in Australia, and I imagine it's similar in many Asian countries, is actually do business cases. And that literature and experience is actually relatively thin globally because the pioneers in the US never had to do business case. They just applied for the subsidy. So we had to work very hard to create a business case to enable that government investment. So that's how it's happened. And I think now we understand more about business cases, and we understand that ROI is not quick. The ROI will probably come with precision medicine and AI in 5 to 10 years. Yeah.
In 2019, the Philippines passed the Universal Healthcare Act, and it specified that the digital transformation and computerization have to be invested in by government. So I think that's a start. But we'd like to learn more, maybe in another webinar, how much you actually invested on it. I hope that maybe some of the things that you've done might be usable on our end, so that will bring down the cost on the LMIC side of things. Okay, so next question is from, and I'm just doing this sequentially, from me. How many people do you have in the Digital Health Center, and what competencies do they have for them and for you guys to run the Digital Health Center? Over.
Yeah, that's a really good question. So the answer to that is 5 years ago, we had nobody. So we didn't have a digital health academic centre. Digital health was largely done by project people or consulting companies, both of whom did a great job. But it became clear that there was actually a lot of science associated with digital transformation, and the universities were slow to realise that. So our centre now runs, I think, about $40 million worth of research money. We have 45 staff and researchers, and we have them across the university. So we obviously have medicine, nursing, allied health, so the clinical leads are really important, but we also have IT, electrical engineering, computer science, we have science, maths and physics, and importantly, we have business economics and law. And it's important that it is a transdisciplinary team, because digital health is a team sport. Doctors who code cannot really do digital health. You do need, that whole team. And I can't emphasize how important it has been to have our colleagues in the business school, the economists. We even have anthropologists, as you can probably tell from my talk, who observe human behavior and help me with that component. So it is truly a team sport. It does require transdisciplinary work and actually quite a lot of science. But can I tell you, it is so fun. I feel like I have the best job in the world because I get to work with such clever people from all across the disciplines. It's fantastic.
And we can see it. We can see it from the way you're presenting and the way you're sharing your stories with us. Is this only for Queensland, and therefore the other states in Australia will have their own digital health centers, and they also receive funding from federal government? Over.
Yeah, that's right. So Queensland has quite a large centre. I have wonderful colleagues across Australia, but we all work together. So, we do work in Victoria, we do work in New South Wales. So we're not just limited to Queensland. We're very lucky that we work across Australia with all our gorgeous colleagues across Australia, and we also work internationally. So although we're based in Queensland, we're very proud of that. We do have a national and a global reach as well.
Which makes it more cost effective, because you're not, the investment is not just one province, but really the whole country. Great.
Correct. Yeah.
All right. Next question is from Dr. Binji. Dr. Binji is actually a public health practitioner. I am amazed by the scale of integration work for a comprehensive regional digital health system. I think it is a good model. I would like to ask if the network used FHIR, that's Fast Healthcare Interoperability Resources, for integrating these systems, or did you use several APIs for better health information exchange between systems which are not FHIR?
Yeah.
Of course, might be more costly and complicated. Thank you for your presentation. FHIR?
Yeah,
Professor.
that's such a good question. So really that question, Binji, is around, do you take a single integrated platform, or do you take a best of breed approach? I think that's really what your question is getting at. So in Queensland, we took an integrated single platform approach. So that has its downsides in that people can't customize their modules as well. They can't own their own systems. We have a single fairly generic platform. However, it has meant that our integration is seamless. So because we're using a single platform, we don't actually have interoperability issues. And the person who goes to Cairns, their information is available when they front up at the Gold Coast, 1,700 kilometres south. So a single platform has really revolutionised the way that information travels because it's already linked. We have lost some functionality by giving up best of breed systems in several areas, and that's acknowledged. I think that likely the optimal situation is a mix of both, right? And so we're now starting to mature towards that, where we have our single Cerner provider, but we now, and I'm lucky enough to have a federal grant setting up some FHIR servers within Cerner, and we're pioneering it with maternity data. So we have FHIR servers set up in an Indigenous general practice and a fire server set up in an electronic medical record. We've developing the fire standards to create interoperability between those two disconnected services. So I think Queensland's very good in areas that are covered by the platform. Areas that are not covered by the platform, I think we have very poor interoperability, but we're starting now with fire to try to address that issue and mature ourselves. So yeah, great question.
Thank you. A question from Jomel Wong. Jomel is with the Department of Health, the Philippines. As I understand it, Australia has a similar model to the American quotation mark meaningful use policy, initial cash payment, and then recurring fees based on the submission of data. The submitted health data is a relatively small set of indicators. Is the size of the data set more strategic, small now and more later, or is it more normative? Like this is more or less the most we could or should get?
Yeah, great question, Jamel. So Australia is similar, but also different to the US, thank goodness, really. So the issue the US has got with its EHRs, and part of the reason why physician burnout is so prominent in the US, is that documentation is linked to billing in the United States. So there are things you need to document, such as a systems review in a US consultation in order for you to receive your payment for an encounter. In Australia, your documentation is not linked to your billing. So I can, in my consultation, simply write, no changes, continue on, and I will receive exactly the same payment as if I had written 3 pages of notes. And I just did a bit of a conversation with a colleague in the US, and we looked at the length of notes between the US and Australia on a vendor, and the longest Australian note is still shorter than the shortest US note. And that's because the US has to really, have this documentation in order to bill. So we don't have that issue in Australia. Australia runs on what we call activity-based funding, and the coding for the event does come out of our EMR, but it's not linked to notes, it's linked to diagnoses. So it's simply linked to events or diagnoses, not the actual documentation itself. So it's slightly more, I think, sophisticated than the American model, and means that we avoid things such as large amounts of copy and paste and note bloat. Yeah.
We'd like to get access to that evidence, Professor Claire, because the Philippine system is patterned. The Philippine medical and healthcare system is patterned after the American healthcare system.
Oh, okay.
So,
yeah.
Copy-paste problem right now in the Philippines. And if you really look at what's being written,
it's not beautiful.
They're just doing what they were doing on paper electronically, and it's not really very efficient. So if you can send us the paper where you compare the length of notes and the effectivity. And I also
just a conversation, Alvin. I hate to say it, but we just pulled up the numbers and had a look. We haven't published it yet. We should, though. We should. You're correct.
We'll wait for that. I was hoping that we would have also the health insurance agency people in this call, because the way they write the policy will matter a lot. It
will, and certainly we know that linking documentation, notes themselves rather than diagnoses to billing does result in physician burnout and note bloat. So keeping it to the actual clinical events, however you write them, certainly to us looks as though a more efficient way and protects clinicians from becoming data entry clerks and keeps them as clinical decision makers, which is what we need them to be, right?
You mentioned about adaptive change. You had the slide on it. I think, to me, that's my takeaway. How do you learn it? How do you teach it? We're taught how to diagnose, treat, and advise the patients. But together as a team, we've started to work collaboratively as teams. But this adaptive change is enterprise-wide. It's even inter-facility-wide. So how did you do that in Queensland? Over.
Yeah. So look, I have to confess, I think we did it really badly at the start. And I don't think we had the academic firepower to understand what was needed. So it was very much a Prince 2 project approach at the start, and that was fine. But it quickly became evident that a Prince 2 approach for complex adaptive change was not going to work, right? Because it's not building a bridge. It is human emotion and human behavior and all of those things that we talked about during the talk. So we had to learn as we went, but what we have done is create a graduate certificate in digital health where we spend an entire module on adaptive change in healthcare and how you do it. And I've just put that in the chat there because, and really, I wish I'd done that before I started EMR implementation, because we didn't understand the complexities of human behavior, that anger was normal, that disruption is normal. And that's things that we work through. We don't panic when those when they happen. We understand that they're normal, and we have strategies to work through, Alvin. So I think the answer is we didn't really at the start understand it well either. So please don't feel bad about that. But what we've made all the mistakes, perhaps you guys don't need to, and certainly have learned from that. And we're now training our people with the graduate certificate in digital health and clinical informatics.
Great, and that's what AHIN is all about. We'd like to learn from people been there, done that, and anything that they can share to the late adopters will be a great help for us. So now we know that there's adaptive change, and if something that we can learn before we do implementation while we're preparing for the go live, then that's something that prepare us for, might have saved me some hair,
Might be too late there, Alvin, but I've got plenty. But no, and what is really important is actually talking to people who have dealt with it before. So we got some colleagues over from the US to sit with us to reassure us that this was normal, and this is, these reactions and the behaviors that we're seeing are to be expected, and it's nothing abnormal or out of the ordinary. This is how hospitals behave when they're disrupted.
So we have 1 minute left, and I'd like to end with an invitation again for the adaptive change. Let's talk offline, Professor Claire, how AHIN as a group can avail of the adaptive change capacity building. We have a network of 1,200 members, and mostly in ministries of health and academe. So I think they're strategic when it comes to learning how to make this preparations for effective technology implementation. Thank you very much, Professor Claire. Final words, please.
Oh, look, have fun. What a wonderful opportunity for you all to lead digital transformation in Asia. I'm so excited for you all. What a wonderful opportunity, and any way we can help, we will.
And welcome to AHIN. Thank you for sharing with us all your expertise. Thank you.
Bye.
So good night. Thank you, everyone.